My name's Kira Wright. I'm the immunisation team leader here at the PHN, and I'd like to welcome you all to our Childhood Vaccination and Infectious Diseases event. I'd also like to welcome those joining us online tonight. Hello, it is a hybrid event, and so we've got the videos going at the same time that we're presenting to you here in the room. I'd like to start by acknowledging the land that we're on tonight. It's the we acknowledge the Aboriginal and Torres Strait Islander peoples of this nation. We recognise their continuing connection to land, water and community, and pay respect to elders past, present and emerging. And I'd also like to welcome any Aboriginal colleagues joining us tonight.
Yeah, thanks for having me, everyone. Can you hear me all right? Yeah, so yeah, that's me. I'll be giving you an update, obviously, on childhood vaccination. I'm just going to probably... all my hands will be full otherwise. Obviously, Kira's done an acknowledgement of the country, but also I think if you've ever interacted with any of our outputs from NCS, you'll see this Indigenous network adorning a lot of it. There's a little bit of background there, essentially, of how. So what I'll say is essentially there's Indigenous piece of art, the NCS outputs. There's a little bit of background behind that, which is around that artwork, really demonstrating the community and kind of the circle of people around those within the community, and really using that kind of community setting to interact and protect the mob, particularly through vaccination. Now, I'll be covering a few topics as noted here. Importantly, some of the information around Vaxelis, which is a new hexavalent vaccine in our schedule, but being used previously or currently in other settings. I'll talk about influenza and RSV a little bit, as we are in winter and we're seeing plenty of that disease around, and then also touch on a few pertinent vaccine preventable cases we've seen mainly in the mass media recently. So Vaxelis. So it's a hexavalent vaccine. It covers the same pathogens as obviously as Infectious hexa does, which is our other hexavalent vaccine now on the NIP. Obviously, Vaxelis is a new introduction to our NIP. It has very similar constituents to Infectious hexa. And one important piece of information around it is that it comes in a pre-filled syringe and you don't need to reconstitute it. Essentially, it's indicated for the primary series in our schedule, which is at 2, 4 and 6 months. In other schedules in other regions around the world, they also have a booster, and hence why you might see some information around it being used as a booster as well. Key messages when it comes to Vaxelis, and if you look at the handbook and information around its use, essentially it's used as an alternative to Infectious hexa, not a replacement. There's no preference between the two vaccines, except for one case, which I'll get to at the bottom. It's to be used for the primary series, which is at 2, 4 and 6 months, we're all familiar with. And it's also suitable to be used in catch-up vaccination, as you might be familiar with if you use Infectious hexa in that context as well. When it comes to vaccinating your children and perhaps they've already had either Infectious hexa or Vaxelis before, the recommendation is that you use the same brand as they've had before, as long as you have that available in your clinic. If you only have the alternate one in your clinic, then you should give that. And not delay vaccination. In terms of the approval process for Vaxelis, obviously it's gone through all of these approvals and landed on the NIP, and we're seeing procurement happen, and in some clinics we're seeing it in the fridges and being used probably in these last couple of weeks. So it's essentially progressed through all the standard approval processes, as you might expect. Just some basic characteristics just to be aware of. It's the same volume, 0.5 ml. It's IM injection. Obviously, it's a liquid suspension and it comes in that pre-filled Luer-Lock syringe. And like I said, 2, 4 and 6 months, it's administered just as Infectious hexa would be. Minimum interval, again, it's the same. It's at least 1 month between doses, particularly those that are a bit late and or catching up a little bit, as we often see. And minimal interval between a primary dose and a booster, if you do happen to be in any setting where that happens, is 6 months. as you expect, contraindications are just those of anaphylaxis to any of the constituents, which I'll touch on in a second within the vaccine. What does it look like? You've got the little brochures there, which helps as well. But essentially, Influenza Hexa, you're very familiar with. It has all these little components there on that little plastic tray inside that box. Vaxelis is a bit different. It has 10 syringes pre-filled in one of those boxes. So as you might understand, that would have a lot of advantages when it comes to cold chain capacity. So in other words, room in your fridge, and also it's already pre-filled, and so kind of timeliness in terms of getting it out of the fridge, getting that needle on the end, and delivering it is probably a bit smoother. The components of Vaxelis versus Influenza Hexa. I put them here side by side and just put in red boxes, essentially, some of the key differences. Slight difference in the amount of diphtheria toxoid in them, with slightly higher amount in Influenza Hexa, which is the first column. And there's one of the key differences is the number of pertussis antigens in them. So Influenza Hexa has 3, but Vaxelis has 5, and has these 2 extra Fimbriae antigens. See if the pointer comes up. No, it doesn't want to. But 2 of those extra Fimbriae antigens there, which is thought to give wider coverage to the pertussis pathogen. The Haemophilus or Hib antigen for Vaxelis is conjugated to the OMPC, or the outer membrane protein complex, which is derived from the meningococcus. This is not something new. This is actually a formulation that we used to have in the 90s and was used as one of the Hib conjugate vaccines in our schedule back then. And really that also touches on another takeaway, which is all of these components have been used in their kind of singular or combined format in other vaccines previously, and rather just being combined in this context to make Vaxelis as one of the hexavalent vaccines that are now available. It is worth noting that though this conjugation of Hib to the meningococcal outer membrane complex does, for whatever reason, induce higher immunogenicity, and I'll show you some of those results when compared to Influenza Hexa. But we think, either way, we still see such good responses that we see good protection against Hib regardless of which vaccine you use. Although Vaxelis is very new to us, perhaps, it's not so new to everyone else, particularly in the Northern Hemisphere. So the European Union have been using it since 2016, and then it's been progressively used in other Northern Hemisphere countries as well. So the USA have had it available for a good few years, and the UK are using it in their schedule now for the last couple of years, as you may have been aware. When it comes to total doses, and so this is useful, I suppose, for yourself, but even communicating to other parents who might see it as something new to them, essentially close to 6 million doses given. So that's quite a number of children, I suppose, being vaccinated with Vaxelis worldwide so far. Naturally, everyone wants to make a comparison with Influenza Hexa, which everyone is kind of very familiar with, and I suppose understand pretty comprehensively. So I'll go through some of the immunogenicity and touch on a little bit of the safety data as well from some of those head-to-head studies that have been performed over the last few years, essentially, which have informed, obviously, those countries we've seen previously licensing it, but also ourselves taking it on into our NIP. So this first study here essentially used Vaxelis in a 3+1 schedule. So that's 3 priming doses, so very similar to us. And then, like I touched on before, a booster dose later in kind of in the toddler years. What you see here is Vaxelis is the red bars and Influenza Hexa is the yellow bars. And what you're seeing is very similar profiles in terms of the immune response. As I said before, slightly better Haemophilus responses for Vaxelis, but still very good regardless for Influenza Hexa. The other thing to note is on the very last bar over there, that you see obviously the higher measures for immune responses for Vaxelis for the 2 Fimbriae antigens which aren't in Influenza Hexa, so as you might expect. Anyway, There was another study as well using a very similar schedule and making very similar comparisons. These are total antibody responses, but I think the takeaway message is essentially is that you see perhaps some slightly higher responses for Vaxelis, which are the blue arrows I've highlighted for some of the antigens, and a couple of lower responses, but overall, sufficient responses for either of the vaccines for what we think would be protective in a programmatic setting. Similarly, after boosting in that same study, essentially the same takeaway messages as I've highlighted here, just the blue arrows, the higher responses with Vaxelis and the lower responses with the red arrows. I think the takeaway message essentially from that study, which also co-administered Bexsero or 4C-MenB, and I'll touch on some of the co-administration information a little bit, is that there didn't seem to be any difference in reactogenicity with either vaccines when co-administered with Bexsero, and also they seem to, the data essentially seem to support both of the vaccines being used flexibly within a schedule. There's also one more study I'd just like to quickly talk about, which was using those two vaccines head-to-head, but in a 2+1 or 2 priming doses and a booster comparison. The takeaway here is really that all of the what we call non-inferiority criteria were met when comparing the vaccines, and that just says that they were comparable in their immune responses for each of those components or antigens. And I've just put in this slide here to summarize the safety. This is how it's published in the paper, which I hate this graph so much because it's horrible colors and it's really hard to interpret easily. But essentially, Influenix Hexavalent is first bars and Vaxelis is the second bar for each of those, I suppose, reactogenicity components there. So things like tenderness, induration, erythema, swelling, and so forth. So you can make those side-by-side comparisons. This was from that paper that also gave the Bexsero vaccine at the same time, but you can see there's pretty comparable, I suppose, reactogenicity between the two vaccines, and nothing really stood out as to one being hugely different to the other. So you can see Influenix Hexa slightly higher for some, Vaxelis slightly higher for some, but really not significantly different for any of them. They did that at each time point. That's just for one of them, but you'll have to take my word for it or to get the paper, but essentially it's very similar profiles I saw for each of those at each of the other time points. So yeah, going into co-administration, which often people have a lot of questions around. There's been a number of studies, obviously, where Vaxelis has been given along the scheduled vaccines, and just depends on the different setting as to what scheduled vaccines those are. So definitely Prevnar, rotavirus, Bexsero, and MMR have been given as part of the routine schedule alongside Vaxelis. And so that's just a summary of some of the data that's been produced from the studies done to date. Kind of in summarizing that, you can say that Vaxelis and Influenix Hexa can be safely given alongside Prevnar 13, Rotarix, Bexsero, and influenza vaccines. For Bexsero, as you know, we do see higher fever incidence when co-administered with your routine scheduled vaccines, and hence the recommendation for those kids to have some prophylactic paracetamol. It's the same recommendation also if you're giving Vaxelis. I think the other thing, to mention is you can potentially, and some people choose to separate out that Bexsero to try and reduce that experience of fever, and if you do that, providing at least a 3-day interval is suggested. For MenA-CWI or no Menrix, essentially it is a tetanus-containing vaccine because those meningococcal components are conjugated to the tetanus toxoid. So we think it's important that you give it together with those scheduled vaccines and not separate that one out for any of the scheduled vaccines, because we theorize there might be some interference and reduction of your immune response because of interference related to giving two tetanus-containing vaccines together. So that's kind of Vaxelis in a nutshell. Encourage everyone just to make sure they've got the updated resources, the new schedule one pager that everyone likes to print out and pop on their walls. And also just check in with the immunisation handbook and get familiar again with some of the updated pages in there as well. The next thing, I'll take questions probably at the end, unless there's really burning questions around Vaxelis right now. And I'll move on to influenza. Very topical at the moment. Essentially, influenza notifications have peaked very recently and starting to come down. So that's the red curve on this graph. Some years, as you can see on that graph, have a bit of a double bump in their season. So we're kind of waiting with bated breath. School's gone back now. See whether we have another increase in flu cases or not, or if it's going to be a little bit like last year, which was a very high peak and then very quickly came down with a very similar profile. So we're just waiting, I suppose, a little bit more to see whether that's going to be the case or not. Overall, over 100,000 notifications to the lab for flu. Over 100 deaths so far notified. And interestingly, I suppose the age breakdown of notifications has been highest in 5 to 9-year-olds, followed by under 5s and then 10 to 14-year-olds. If you look a little bit more generally for flu-like illness, and that's what this graph is showing. And so that in this case, kind of just fever and cough. And so this captures more than just flu. It captures obviously a lot of other respiratory illness. So far this year, which is the black line, you're seeing a profile that largely follows our experience with probably RSV and flu. And a real kind of mixture of other viruses. We're seeing at slightly lower frequencies in there. But if you compare that to 2022, which is the blue or the turquoise line, you see we had a good winter peak, but then also we had a bit of a summer season of flu-like illness, which was all related largely to a bit of, I suppose, post-COVID public health measure catch-up. And so we're seeing some out-of-season viral spreads, things like RSV, and a number of other viruses, COVID for that matter, were spreading around in summer and particularly out of season when we commonly see a lot of respiratory viruses spread around. It'll be interesting to see what happens, I suppose, for the other half of this year, whether we see a bit more of a normalized wintry flu season and that's it, or we do see some out of season respiratory viruses or not. Of course, we've got to get onto influenza vaccine coverage, and it's not a particularly bright topic when you look at the numbers. It's, as you see there, across Australia, averaging about 22% or 23% in 6-month to 5-year-olds. It then halves to a very low 13% in the 5 to 15-year-olds. So basically the school age kids, which are probably a decent reservoir of spread. And then increases, as you might expect, into the elderly, where there's a lot more active uptake and encouragement to take up the vaccine. For the Indigenous population, it's very similar profile of numbers, but obviously lower numbers, which wouldn't be a surprise probably to anyone. Generally pretty similar story across most of the jurisdictions, except for the Northern Territory, where it's been a bit more challenging, I would say, in terms of numbers, but also I suppose we have a not as elderly population in the Northern Territory because there's quite a large population of Indigenous peoples who don't live as long. I'll go into the vaccine coverage a little bit more in detail because it tells some interesting stories. So first of all, this graph just shows coverage for this year over time and also by age. And so it reflects that table I just showed, but you get a good sense that obviously the elderly are taking up the vaccine much early in anticipation of the flu season. And then also the children take it up, but very gradually. And maybe perhaps there's a little uptick in some of the child populations late in the year or in the season, so to speak, in reaction to disease circulating and or I suppose public health messaging. If you look at the children particularly, and this is the interesting group, as I said, because they make up the bulk of notifications, particularly this year, you'll see that over prior years, the first year out of, or during the pandemic, sorry, 2020, we saw very high uptake compared to other years subsequently. And this was related to, I suppose, very, very strong public health messaging around trying to get your flu vaccine to prevent you being hospitalized in the context of the COVID pandemic. We're not seeing as good uptake, obviously, in subsequent years. And as I touched on, we're seeing little upticks in some of the age groups in some of those years, particularly last year, later in the year, which seems to be a reflection either of messaging, but also possibly of community realization that there are cases circulating and wanting to vaccinate. And you can see that's happening, right in the peak of disease, as I showed you earlier. Does the flu vaccine work? Lots of people wonder. But there's very good data to show that it does. And when it comes to hospitalization, it reduces your risk by 50%. And so that's what that graph over there is showing. That little dotted red line it is averaging out all of those little blue dots in their confidence intervals. Essentially, the takeaway from that is that red line, but there's little breakdowns essentially you can see there in different kind of criteria, whether you just look at children under 16, which is the bottom green bracket and blue dot, you should see there's quite good efficacy there, almost kind of 60% with regards to hospitalization, but variations depending on your category and or the type of flu you're trying to prevent. But yeah, overall, very good, regardless of who you are when it comes to preventing hospitalization. If the vaccine wasn't effective at all, you'd be seeing a dot over where the 0 is. I've added that in, that's why it's bigger, just to make you get a sense of how effective they are and how far away from the 0 those lines are. There's often common questions every flu season around vaccination. Some of these are a reflection of some previous recommendations. Around kind of flu vaccine delivery and latex and egg allergies, essentially the recommendations now are to essentially just press on and vaccinate those populations. With regards to co-administration, it's very similar as well. Perfectly safe with co-administration. The only kind of caveat there I've highlighted is essentially co-administration with Shingrix, which will be usually in your older populations. That fluad quad can be given the same day, but you do see some increased reactogenicity, and so you can potentially separate it by about a week just to reduce that, particularly in your perhaps your extra frail clientele. If it isn't co-administered, essentially any interval is acceptable other than the one I just described for Shingrix. Additional doses of flu vaccine, really there isn't any additional doses. The only caveat again to that you're probably all aware of is that if you're under 9, you've never had a flu vaccine before, then we recommend giving 2 doses, which are separated by at least a month. Safety of flu vaccine. So Ausvac Safety collects and surveys a lot of people that have had a lot of the vaccines that we have on the schedule, and these are some of the data that they've collected. So essentially collected a lot of surveys from a lot of people who've had the flu vaccine, and touch on some of the subgroups here. So looking at the kids who are 6 months to 5 years, nearly 8,000 surveys completed, and of those, about 1 in 5 are reporting some kind of adverse event. And when you look at what those are, it's nothing really that probably will shock you, but you're seeing some local reactions, about 13%, some fatigue in 12%, and probably the next one that stand out is fever in about 1 in 10. Okay, and there's a little bit of smattering of headache and muscle gastrointestinal symptoms, although you have to understand that the younger population there would not be able to report some of those symptoms. In pregnant participants, this is often asked as well about safety of flu vaccine, and we obviously deliver it, try and deliver it to as many pregnant people as possible. We've got 1,500 surveys so far, very similar prevalence, so about 1 in 5 reporting some kind of adverse events, but the profile is a bit different to children. So we're seeing mostly local reactions of fatigue, some headaches, muscle joint, but not a lot of fever in this population. So 2%, which is 1 in 50, and not a lot of gastrointestinal symptoms. So key messages. Influenza vaccination is obviously recommended for all people aged 6 months and older, but obviously there's quite a big differential in uptake across the different age groups. Co-administration obviously is safe with one or more vaccines, and also consider opportunistic vaccination. Like I said, we're not too sure whether we'll have another bump in our season, so it's still not too late to have your flu vaccine if you haven't already had it, would be what I'd be messaging to a lot of my clients, seeing them in the clinic. And obviously trying to vaccinate not just those that you're seeing directly, but their family members and those they're in contact with. And reporting obviously all vaccinations as we should in the AIR. All right, RSV, one of my favorite viruses. So respiratory syncytial virus causes a flu-like illness. Not sure how familiar a lot of us are with it, but it's going to start to be talked about a lot more in the mainstream media for a number of reasons. It is the biggest cause of morbidity and mortality, probably from a respiratory point of view, amongst children at least across the world. Very contagious, as you know, very typical symptoms, but it's a frequent cause of wheezing or bronchiolitis and or increased work of breathing in infants and definitely children under 2 years of age. There's no specific treatment essentially, except for a very hard to get monoclonal antibody, which is very expensive and only used in really, I suppose, prone children prone to death should they get RSV. So yeah, it's all supportive treatment, paracetamol, ibuprofen fluids, and then supportive respiratory support should they come into hospital and need it in that circumstance. The other important note is that RSV is a notifiable disease now, and has been now for a little while, and cases are being monitored, obviously, nationally. So I think that's something that a lot of people haven't quite picked up outside of the hospital setting just yet. Burden of disease of RSV is probably quite large, although not well measured. We're starting to count cases better, at least, because it's a notifiable disease. And as you can see here, just with the notifications across the year so far, it's a pretty progressive, steady build. RSV season usually is the first virus, or one of the first viruses we see, and then flu comes afterwards, and you see quite a number of cases, particularly amongst children under 2 years of age. Almost every child by 2 years of age would have seen and had RSV infection at least once, and almost certainly by 5 years of age, everyone has seen it a number of times and has pretty good immunity when you measure it at that stage. It causes a lot of hospitalization, as I said, in the under 2s and also the over 65s. And there are going to be some interventions coming soon to our setting, but firstly to the Northern Hemisphere. So the US has just essentially recommended and licensed both a vaccine and a monoclonal in their setting. They'll probably be using it for their coming winter. It'll be interesting how it changes our experience here, because it causes so much disease, and whether we really will be seeing a significant reduction in hospitalizations and how busy the kids' hospitals are over the winter. But in terms of vaccine development, they're in the very late stages. In fact, a lot of the phase 3s, which are the late stage trials, have finished, and the data are coming out from those. And you may even see it starting to be reported in some of the mainstream media. I have not been involved in any of those articles, but some of my colleagues might have been. Just to summarize, though, the vaccine efficacy for a lot of these products is quite good. So in the over 65s, it's over 80%. Similarly, for the vaccine that's been used in pregnant women to try and prevent RSV disease in the newborn infant, the efficacy is about 80%. And similarly for the monoclonal antibody, which is actually a Sanofi product as well, Nirsevimab, it has just over 80% efficacy in preventing hospitalization in children that have had it prior to their RSV season. So you'll be seeing a lot of these kind of headlines, I suspect, over this next 12 to 24 months related to RSV. And we may, particularly those people working in primary healthcare and hospital settings, you may even start to see a shift in presentations if we do see a programmatic rollout of these kind of products. Similar to perhaps most recently things like the rotavirus vaccine being rolled out, and the changes in really not seeing whole wards of kids with rotavirus each year. Potentially putting me out of a job as a general pediatrician. All right, getting close to the end, and then we can open up to some questions, but there have been some cases of vaccine preventable diseases, just reminding us all the time that we need to obviously try and keep our coverage up as best as possible. So there have been cases of diphtheria, particularly in the Northern Rivers region, where there's particularly low coverage of the primary infant program amongst that population. So that those kids having to end up in intensive care on the Gold Coast, essentially. And there's been a case of tetanus and a death from that in an elderly woman just recently, and that hasn't been seen for a long time. I mean, and those pathogens are still and always with us. They're in the environment. They don't go away. Okay, and that's the need for vaccination, constant vaccination all the time for everyone as they come through their infancy. Measles has also been a little bit topical, and particularly in Western Sydney, where we have a relatively large population of people from South Asia. There's been a lot of cases in South Asia, and so we tend to import measles from there at the moment. And there's been, or was, a number of alerts around some of the cases that came in, particularly just after the holidays, I think, around March this year. It's important to be confident with recognizing measles, so identifying these cases, asking the travel history, and where they've been found, and having a bit of a sense of where some of the measles hotspots at any given time, because they do change. That's number one. The other thing is also understanding who needs to have catch up. And so there's a little algorithm, which is a little bit complicated here. But if you first of all start off when they're born and or how many doses they had since, you can start to work out whether they need a top up with their MMR vaccination or not. And or some serology may play a role in that. The other, I suppose, point with measles vaccination, particularly of travel on your mind, is that there is a recommendation that you can give the measles vaccine from 6 months onwards for those going to high disease burden locations, but that doesn't stop them from having to have their 12-month dose of MMR. The other thing to mention is the service I work for, which is the New South Wales Immunisation Specialist Service, or NSWIS. We provide obviously a range of support for you, whether that be over the phone or via email. So you guys can call us up. You just have to call through Switch at the Kids Hospital at Westmead any time of the day, or you can email them through to our service as well, and we usually get back to you that same day. And so that's the end for me, and I'll invite any questions from the floor to begin with, and they might come from online as well. I'm seeing some nods at the back, so there's definitely some online questions.
I have a question from online. Regarding influenza vaccine for pregnant women, if they've had a dose of the flu vaccine prior to falling pregnant, do we revaccinate during pregnancy?
It
depends on the season, but generally yes. And then the interval between.
I suppose the vaccine. So it's not a straightforward answer. You need to know more details about that timing of the dose.
Another question is the rotavirus vaccine injectable, oral, or inhalant?
It's just an oral vaccine. So it's given at the 6 to 8 week checkpoint and the 4-month checkpoint, alongside Prevnar and Infectious Hexa or Vaxelis, and it's an oral vaccine. The other two are injectable.
Sorry, what does the RSV vaccine look like in terms of scheduling? The RSV vaccine going to come out, how many doses and what will sort of the dose interval be or time we'll give it?
Yeah, good question. It depends on the product. So the monoclonal antibody, which would be a passive vaccine for infants, it's going to be just a single dose. There's a couple of I suppose strategies put forward as to how to deliver that, because obviously RSV comes in a seasonal wave. So what time do you vaccinate your child, knowing that that antibody only lasts 6 months? So they're thinking of giving it before the season for every newborn or anyone in their first year of life. But then also potentially you could give it throughout the entire year, just knowing that it does wane, but it may have kind of variable efficacy. So they've tried both of those so far, but not in a kind of a wide program. Both seem to be effective, but it's hard to say how effective either of those are going to be until we actually use them in the real world. For the one in pregnancy, it's obviously an intramuscular injection. You're generating antibodies to one of the surface proteins of RSV. It's likely to be a single dose.
I'm interested in the answers in-person consults. Can we get the slide before? How do you access that? Is that through your emails or do you ring the Sydney Children's Hospital?
Yeah, so in-person consultations, I suppose what that means is essentially those are largely what we see through our AFI clinic. So they're people that have had prior reactions to a vaccine and want to be reviewed by one of our specialists. So those children will come through our clinic. You just send a referral to that email address. We pick them up and we contact them and book them in.
Yes. Yeah.
Yeah. Yeah, it is. And Randwick also have a clinic which is run by their Pediatric Infectious Diseases Department. They don't run it as often, but obviously because you guys are in obviously their catchment, that's also another way to potentially access a review of at Westmead Kids. Yeah.
Does RSV behave like influenza in the sense that there's an antigenic shift in the actual virus, or is it just always the same?
Yeah, good question. It's one of the ones I'm putting forward as well as, what will we see? How will the virus adapt to a clinical intervention? We don't know because we've never used any clinical intervention against it. It seems to be, at least looking at it genetically at the moment, to be not particularly diverse. But at the end of the day, you won't know until we actually interrogate it. It's the key risk to those interventions, which target a very specific surface protein, is that it manages to shift away from clinical intervention and evolve away from it and make it less, I suppose, effective. Yeah. So, but we would have to essentially watch very closely disease after we introduce these products.
Sorry, I'll just get you to speak it into the microphone.
Kira's
For the people online.
Thank you. Just a question about the influenza vaccine for the under 9s. If they miss the second dose of the flu vax for the first year, second year, do you need to catch up the 2 or just to carry on with the 1?
Yeah, good question. Generally, I think we've been carrying on with 1. The rationale really comes down to because particularly the younger kids, they haven't had any flu experience, whether that be vaccine or otherwise. They have very limited response to the vaccine and also very limited underlying antibody already. And so that's where the 2-dose recommendation has come from. So if you've already previously had a dose the prior year, then you simply just have a single dose the subsequent year, because you already theoretically have some experience then already under your belt.
From time to time in general practice, we do swabs on our patients and we get Bordetella parapertussis.
Mhm.
Can you please tell us if that is a different organization from pertussis? And because the treatment is the same, I gather, but is your immunization the Vaxelis? Is it called Vaxelis? Like Vaxelis, yeah, is the new one
Mhm.
Going to be helpful to this Bordetella parapertussis, because you've got all this other extra fragments that you've said?
Yeah, I haven't seen studies looking at the cross protection for parapertussis, to be honest. Yeah, so I'd have to take that on notice. I'd have to look it up. Yeah, good question. I haven't seen it a lot in my practice, but interesting, yeah.
Influenza, deaths due to influenza, what are they actually caused by? What system is affected? And can a person that's immunized for influenza actually die from influenza despite the immunization?
Yes, so there's a few components to that question. But yeah, I haven't seen the data in terms of a breakdown of those 100 deaths, to be honest. There's probably a variety. As I know, looking at general kind of influenza deaths, there are certain pockets of the population that are much more susceptible. We've seen some deaths in kind of and very unwell children, essentially, who are in the kind of the teenager years, particularly this year because it's been a flu B year, which tends to affect children more. But there's a whole range of reasons why people die from flu. It can be largely just the overwhelming respiratory compromise that occurs, and that's largely what happens in otherwise healthy people. But a lot of people, particularly the elderly population, have a lot of comorbidities. So it's a combination of all those factors kind of working together and having limited reserve at fighting it off. Often there can be co-infection with bacteria as well if you have a significant flu infection, which can affect obviously you and your. The other part was about the flu vaccine, is that right? And sorry, does it prevent death? Yes, yeah. Well, I mean, essentially it does. It's implied by the fact that it prevents hospitalization. So if you don't go to hospital, you're less likely to die. But also if you're less sick, and if you by factor you be less sick, you're less likely to transmit and less likely to also subsequently cause someone else's death or illness for that matter.
Rama, I just have a few more questions from online. One is about the Vaxelis vaccination. So obviously that is funded for Aboriginal and Torres Strait Islander children under 2 and recommended for all children. Is it just 2 doses primary, or is there a booster dose, so 3 doses required?
Depends on your age when you start. So yeah, essentially if you're starting early in life, then you have so I think it's before 9 months or thereabouts, from memory. You have your primary series of 2 doses and you have a booster after 1 year of age. If you start afterwards, then it's just the 2 doses. It's a little bit complicated because there is some messaging, and even in the product information, it does say that you can have a booster dose regardless of age, but it does, as you'll see, the recommendations in the by Atagi in immunization handbook differ from what's in the information.
When all else fails, look up the handbook.
Can I just confirm, you said 9 months. I thought it was 12 months. When it's under 12 months, you need 3.
I think so. You have to check. But I thought it was when you start. So you got to have 2 doses separated by 8 weeks. Yeah. And then you have your booster after 12 months. So you can't feasibly do that after kind of that 9-month mark very easily.
Is Infinrex Hexa being phased out?
No, not that I'm aware of. So I think they'll both be supplied. And when it comes down to procurement, I don't have any insight to that. That's all done at a government level, and comes down to probably largely supply, partially to costs and all those things that we never hear about. But I suspect it'll be around for a while yet.
Because there's no other vaccine that you can order. You can choose what you want to order when you order online. Like you can't pick a brand when you order. So
Okay, so that would mean then, you know, there hasn't been procurement from your supplier yet.
Oh, well, that's when you order off the New South Wales site.
Yeah, but in some settings, they've already been able to receive Vaxelis supply and have been using it.
So the State Vaccine Centre, they you kind of just get what you're given, but I think in most cases they will try to give you some of both, because sometimes, you know, you'll start these new kids on Vaxelis, so you'll need that, and then other kids will be on Hexa, so you'll need that too. So if there's supply, they'll give you both.
Yeah, it's kind of you don't necessarily have a choice, I think, in a lot of it.
Hi, just a question with regards to the service that you provide. For the immunisations, is that all immunisations and you keep them on stock, or do the patients bring certain ones with them?
No, they're all provided through the hospital pharmacy, unless they're
Travel vaccinations?
travel vaccines. yeah.
Okay, so if it's for children or adolescents who are difficult to immunise,
Mhm.
say special needs or anything like that,
Yep.
do they require an appointment? And then if they've got a prescription, can they purchase it at the pharmacy?
Yes, so it depends on the travel vaccine as well, and the context. It may be in the pharmacy. It just depends what's on stock, because some of them aren't necessarily going to be widely used in the hospital setting, and we can order it in. Is the other option. But yeah, for those kids, it's send a referral. I actually lead that clinic, so it's send a referral to me at that email address, and we book them in and assess them pretty significant detail prior to work out what's the best approach, and then immunize them.
Is this the clinic that I was reading that they've currently got at Westmead Kids Hospital, offering like flu vaccines for children and their families, any age?
So that would be the essentially drop-in calls, which is just being kind of restarted up. So it operates under our umbrella, well, with our help, I suppose, at the moment, but it's separate to these clinics. Yeah.
Thing within this area that's free flu vaccines for children and their families over the age of 5.
Over the age of 5. No, unless you manage to acquire it in the hospital setting. Yeah.
Thank you.
So there is a move to try and set up these drop-in clinics, particularly at the kids' hospital, and hopefully wider as well in the other key hospital sites around the metropolitan.
Questions? I'll just have another look online as well.
That also obviously the policy recommendations around flu obviously reflect why you see that coverage as well. To an extent, the coverage is still low regardless.
Rama, we just need a clarification on the tetanus containing vaccine slide.
Yep.
Can we give limericks with Infectious Hexa or not?
Oh yes, so the recommendation is to give it together and avoid separating it, would be the takeaway message there.
Great.
I'm trying to find the slide, but it's a long way back.
Okay, and another one just on pregnancy, which is always, this question comes up every education session we do, pregnancy and flu vax. So for example, if they had a dose of 2023 flu vaccine in May, then fell pregnant in July, what would be the optimal timing stage of pregnancy for revaccination?
Sorry, they fell pregnant when?
July.
July. Will they go across into the next season? No, I don't think you'd have a vaccine. The next season's vaccine available by the time they get towards their last trimester for that matter. And they've already been vaccinated. you know, look, it's a patient decision, to be honest, in that case. I would suggest, because pregnancy is a risk group when it comes to flu, that you might think about having another dose towards that last trimester.
Great. And then some patients are required to have flu vaccine and Prevnar 13 together. Is there any interference, or can we co-administer?
That's perfectly fine to co-administer, yeah.
Thank you. All right. Do you think there's a chance of a combined influenza and RSV vaccine in the future?
There's a chance, particularly if it's going to be used in a seasonal capacity, but I think not in the initial context. I think they'll be separate products to begin with, but you might, hopefully we'll see them combined. I think one of the other things, as you're touching on there, is suddenly you've got an RSV vaccine, you've got flu vaccines, you're having Vaxelis potentially as part of your schedule. It becomes very burdensome in terms of needles. And there's definitely a need to try and rationalize the schedule as we go forwards, particularly with new products potentially being incorporated into the program. So whether that's reducing the number of doses or starting to have more of those, as you say, multivalent type vaccines is going to be important, because it's probably the first question a lot of us get in the clinic setting is how many needles we're having this time.
Great, thank you.
Sorry, just to answer the question about whether you can order Vaxelis or Infectious Hexa, can you choose? On the New South Wales Vaccine Centre website, there is an option to order one or the other. So there's one option to order Vaxelis and another option to order Infectious Hexa. So you can choose.
Or do both. Or both. Yeah. Or
both.
Great. If there's no more questions, I would like to thank Rama for tonight presenting and give him a round of applause. Hi, so you now have me for the next 20 minutes or so. I'm going to be talking about managing overdue reports. So that's childhood reports. I just wanted to see a quick show of hands if you or your practice receives an overdue report from us at the PHN. 2, 3, 4. Okay, excellent. Well, we are currently sending reports to over 300 practices in our region. So maybe a few more of you might, but someone else is managing it for you at your practice. And that list is ever growing. So if you'd like to add your practice to the list, there's a link in the evaluation at the end of tonight. So I wanted to start with why it's important to follow up these overdue children on these lists that we get. So here are the current coverage rates. So this is March 2023. Can anyone tell us what the national target is? 95, thank you. So we are not achieving, we're doing great, but we could do better. So I won't go through them, but you can, read them. They're mostly over 90, but yeah, we can always be doing better. And then this is the immunisation coverage rates just in our region. So our region covers the Sydney Local Health District and the Southeastern Sydney Local Health District. And as you can see, there's been some movement over the past 3 years. And then, as COVID hit, we can see that bit of a decline over time with the vaccinations. And I'm sure you've all heard about it, the vaccination decline, some vaccine fatigue, things like that. So yeah, that's just kind of painting the picture as to why it's important for us as nurses, GPs, to follow up our overdue patients. Centrelink and Medicare send out letters. They send them out to children that are eligible for Centrelink payments at 10, 21 and 54 months. And then Medicare send out letters to all other children at 7, 13, 15, 19 and 49 months. And then once children become adolescents at the age of 14 and a half, they are no longer, the parents can no longer access their child's medical record, and it's up to the adolescent to get it themselves. And then that's when the adolescent is sent their vaccine catch-up reminders. And on the adolescent ones, at 14, 17 and 18 years of age, it has all their childhood vaccines that they haven't had as well. So there's the whole list on there for them to go and catch up with the GP themselves. So there is work being done out there for the patients to get themselves vaccinated, but it's always great to be another reminder as a practice. So the AIR reports that there's heaps of AIR reports available, but these are the important ones in terms of catching up overdue children and adults. They work on adults too. So the AIR 42A report is specifically for COVID vaccinations, and you can search it by no doses, 1 dose, no dose in the last 6 months, etc. You can do age ranges, all the things. So that's a really good report for catching up COVID vaccination. And then for other NIP vaccines, you can use the other reports. So the 10A and the 11B are the ones that you would use as providers. 10A is by practice, so it uses your PIP ID. And then the 11B is by vaccination provider, so it uses your provider number. And then the 11A is what we can access as a PHN, and it's what the public health units and the states use for their overdue reports and coverage. Here's a little comparison of all the reports that I just mentioned and how, you know, what parameters you can get out of the report. Yeah, it kind of speaks for itself, but it shows, you know, the differences between the reports. So when you receive an overdue report from us, or if you download it yourself via the 11A, 10A or 11B, it'll look something like this. These children all started with the surname A, but you can tell where the child's differentiate. So if we look at child 1, we can see that this child is almost 4 years old now, and they're still overdue for their first dose of a lot of antigens. So by that, we can see it's their 6-week vaccinations. So this can be, you know, your first kind of red flag that there's something going on here. So the child, you know, maybe could have moved overseas. They could have refused vaccines from birth. They could be a duplicate record. And, you know, this was created when they were born, and that's, you know, and then the vaccines that they have had is on another record with their name, etc. Another red flag is that there's no Medicare number. So it's probably likely that this is a duplicate record. And then, you know, all the vaccines that they've had is on their other record. So yeah, so overview that they've either left the country just after birth or it's a duplicate record. So to go through this in your practice, you would identify the child in your practice software. You'd then click your little send, you know, merge with AIR button, and that will, if that then says that they're up to date, then that again is another red flag that there is a duplicate record. And then in this case, you could let AIR know that there is a duplicate record for that child. You notify AIR by the secure messaging on HPOS Proda, or you can call them up. This second child is just a single antigen is missing. So again, red flag, that's an easy one to catch up, to fix up, because especially in dose 4 for polio, there is, you know, usually a combination vaccine for that. So something's happened in terms of the data transmission. So you can, you know, easily notify that error to AIR and get it rectified. Other little tips and tricks with the report, things to quickly get out of, you know, get children quickly off your list is the duplicates and the non-Medicares. If they're non-Medicates, most of the time they are a duplicate. So you can find them, you know, on AIR using their name, date of birth, etc., and then send both those files to AIR and say, please merge. And then again, that single antigen that I just showed you is a red flag for a data error issue and easily fixed. Looking up the child's vaccination record. So yeah, as I said, you can look up via your practice software, then use the view in air button. And then if that tells you that the patient is up to date in air, then that is that red flag that you found a duplicate record, and you can log into air and give them, send them the details of both records and they'll merge that for you. If you have a report full of kids that have moved overseas, this is very common, as the second someone gets a Medicare number, they have a file on air, and by the same note, anytime someone receives a vaccine, they have a file on air. So a lot of the time, patients might receive one vaccine here and then move overseas. They might, go overseas for a few years and come back when they start school, things like that. So what you can do is, if you have evidence that they have moved overseas, so you can look up, through patient files, maybe someone's mentioned they're moving overseas, family members, other people in the family may have mentioned that. If not, you can also, by following up and being lost to follow up, you can assume that they have either moved overseas or interstate, and you can click this return mail indicator. What the return mail indicator does is that it stops them being counted on the air, the coverage rates. So they won't be counted anymore, taking up room in that under-vaccinated population. And then as soon as they come back into the country and receive a vaccine, they'll be, the return mail indicator will be taken off and they'll come right back into the system. So when you tick that button, it's just that they're like put into like kind of sleep mode. And yeah, if they come back into the country, or if they have another vaccine somewhere, then they'll just be reissued that same account. Just checking my notes. Contacting air, as I said, you can log in via Proda, HPOS, select the messages tile, and then select the air drop down button from that list there that I pictured. You can also call them to let them know, depending on calls coming through, you might get straight through or you might be on hold for a while. So yeah, whatever you prefer. When we send you the overdue list for your practice, we also send you this action sheet. And this kind of goes through all the actions that might be necessary for you to help these children come back to up to date. So it goes through duplicates, moved overseas, up to date status is incorrect. So, data entry error or alike. Child moved out of area, truly overdue, and lost to follow up. So just a zoomed in version here. Yeah, it kind of gives you, the actions for whatever situation arises from you going through your overdue children. It's available on our website, and as I said, also is a link in the email that we send you. And you'll get a link to it with your follow-up email tomorrow. And, once you start going through the kids, as I said, going through those easier ones first, if you've only got, an hour to dedicate it to it for the first month, find those single antigen ones, find those duplicate ones, and, you quickly start getting traction, and your overdue report should look shorter and shorter month on month. Keeping your overdue list small. So children are flagged as overdue by air 1 month after their due date. So if you ensure your practice has an active recall reminder system in place, then hopefully these kids never fall into that 1 month past due date. Ensuring all practice members acknowledge any prompts. So, that might be about having a staff meeting within your practice and making sure those GPs don't just click through all those prompts as they come up, and that they're acknowledging, if a child is sitting in front of them with a cold, but they're overdue for XYZ vaccine, that they have a chat about that as well. Add a phone call to the recall reminder list if you have capacity to, and not just relying on the SMS or mail, if anyone mails anymore. And be ready to discuss any queries or address vaccine hesitancy. So Sky is really helpful for vaccine hesitancy conversations. We also recently had a webinar with Professor Holly Seal, who's an advocate for, what's the word? Science. Anyway, she wants everyone to know all the information there is to know before. Yeah, so you can go and watch that webinar on our website as well. I just wanted to show how the work that we've been doing in sending out these reports to practices and the work that you guys are doing within your practices is actually making a difference. So we started a project in the eastern suburbs region in Q3 of 2020. It was, an intense project. If you work at a practice in that region, you might remember. We, worked really closely with the practices to help get those overdue lists down. And our ranker won the 31 PHNs in Australia when we started this project was 20 for the 1-year-olds, 27 for the 2-year-olds, and 30 out of 31 for the 5-year-olds. And then, as we've done this work and over the years, we've kept it up and we've increased our reach, and now we're working with over 300 practices, and now our rank has gone up to 11 out of 31 for the 1-year-olds, 15 out of 31 for the 2-year-olds, and 27 out of 31 for the 5-year-olds. So we're slowly making a difference, and it's with all you guys doing your work on the floor. So thank you. And just this graph again to show that red line is kind of where we started our project. So you can see the data. Going up. It's amazing. So yeah, we just got to keep doing it. I know it's getting harder and harder to kind of factor everything into your work lives as GPs and nurses, but obviously childhood vaccination is very important. So if we can achieve 95, that would be amazing. Just quickly, influenza, Ram already touched on this, but I just wanted to show you the rates, which are pretty alarming. So yeah, just again, anytime any patients are coming in, always checking if they've had their flu vaccine, encouraging them to have it, sending out reminders again. It might be the end of the season, but it's nowhere near in the minds of what we looked at. So yeah, just constantly reminding people that it's really important. And then for children, the same thing. But just highlighting that you can also run reports to find exactly who these patients are. So obviously, most of you will have Pencat or Polar, and you can run reports of patients in your practice that might have had the vaccines. But, in today's world, people go to lots of practices for different things. And so if you run the reports through AIR, that's your source of truth. And so, yeah, you can run a report which is antigen specific as well. So for flu, you could run the 10A just looking at flu for certain age range and get a list, because it's serviced by, the list is produced by the last vaccination service provider. So they're all your patients at some point or another. And just lastly, reminding you all about cold chain. Lots of quickies here. Cold chain management training, the HEDI course. I hope you've all done it. If you haven't, we'll send you the link tomorrow as well. Do you have the best data log you can? We had a phone call the other week from a practice that didn't realize that they could only get a new cloud-based logger if they bought a new fridge. Because I think it's the Aquarius box or something that comes in the fridge. That's one type, but you can just buy cloud-based loggers. They only cost a couple $100, and then every time your fridge goes out of range, you get a text message to your phone. So yeah, just making sure you've got the best data logger you can to make it as easy as you can for your practice. And that's me. Any questions?